I hope you all had a good coffee break, and I noticed that we failed in our fellowship duties, being 5 minutes late back. Never mind. We now continue with the morning session. For those who haven't spotted, we did make a slight flip in the arrangement to put Chris Ham before Professor Michael West. So anyone who's new and who is expecting to see Chris Ham will now see Michael West. Well, it's a great privilege and honour to introduce Michael, who is a Professor of Organisational Psychology in Lancaster, but tells me he will shortly be going and spending more time with the King's Fund, which is, I think, what happens to very senior people. They gradually end up working with the King's Fund. And if you aren't working with the King's Fund, then there's obviously something wrong with you. Chris, can I talk to you at lunchtime? Michael has done a tremendous amount of work which is of real relevance to the things we've talked about. For me, some of the work that was done on teams actually changed the way I thought and the way I organised things. And I was particularly interested reading the work. He did a lot of work about pseudo-teams, of groups of people who pretend to come together as a team, but actually when you look and watch them, they're not behaving as teams. They're behaving as, 3-year-olds in developmental in development. You give them both Lego sets and they play in parallel, and it can be very easy to think that they're actually playing together, but they're not. They're playing in parallel. And if we follow on from where we were talking and Chris was talking earlier on, a lot of the stuff we do in organisations is still playing in parallel rather than actually tackling the task and playing together. So Michael is going to talk to us about some of the aspects of leadership and quality, because quality and good services for patient is the unifying thing for all doctors, all clinicians, and, believe it or not, all managers. So over to you, Michael.
Well, good morning. It's a huge privilege to be here. It's a resoundingly silent place. It's a real pleasure to be here and a privilege, and a huge thank you to FMLM for giving me the opportunity of having 20 minutes to talk to you. It's a great privilege. Leadership is just the most significant influence on culture in organizations. And culture is the way we do things around here. It's the difference between patients being treated with sensitivity and compassion and care and being engaged, and patients being treated as tasks and being dehumanized. And culture affects everybody who comes to work in an organization and changes their behavior. So understanding leadership is hugely important. And it seems to me particularly important in the context of healthcare. If we are committed to healthcare being evidence-based, that we should also be committed to our application of leadership being evidence-based. And there's so much written about leadership, there's so much talked about leadership, and the challenge for us is to winnow out that which is evidence-based from that which is fad or fashion. And it's a real privilege for me to be working in conjunction with the King's Fund and with the Faculty for Medical Leadership and Management and the Centre for Creative Leadership on a review of the literature, the published literature on leadership in healthcare. And I want to talk about some of the findings that are emerging from that research, as well as from other research that I'm currently involved in or have been involved in of late, and to pull out from that some lessons that I think are important for all of us who work in this sector. So the first study I want to mention was published about 3 weeks ago in the British Medical Journal Quality and Safety. And it's a study of the extent to which there are cultures of quality and safety across the English NHS. It involved something like 300 interviews with stakeholders, the research team sitting in A&E units, in wards and intensive care units for a total of over 650 hours, watching what went on, the way things were done in those organizations. It involved surveys of over 650 clinical teams and the analysis of board minutes from 70 trusts over an 18-month period. I am actually 24 years old, but this study has aged me considerably. and the second source of data is the National Staff Survey, which has been running since 2004. And so we have longitudinal data from an absolutely enormous sample of people and of organizations, and it's possible to link those data to data from national outcome data, like patient satisfaction surveys, data on mortality, infection rates, CQC indicators of care quality and financial performance. It's just a real treasure trove of understanding about leadership and about culture in the NHS. And from that research, I want to talk about, and the research on leadership and outcomes in general, I want to talk about 5 areas that I think are particularly important. The first is, what emerges is the importance within cultures of having an inspirational vision focused on high quality, compassionate care, and that is prioritized. And I'm sure you'd all agree that that sounds like a worthy commitment. And we saw in every trust that we worked in across England that they all had inspirational visions. But when we looked at board minutes and over an 18-month period, what we found was that very often boards did not discuss quality as an agenda item. If they did discuss quality, it was in relation to some other factor, and a lot more time was often spent discussing other issues like financial performance or meeting regulatory targets and productivity and cost cutting. Leadership is really important for cultures. What we value is not what we say so much as what we spend our time monitoring, focusing on, discussing, rewarding, reinforcing, appreciating. And what we found was that where boards were not so focused on quality, the National Staff Survey data revealed that staff felt they were less able to deliver high quality care and felt less supported than staff in trusts where the boards did seem to be, by evidence of the minutes, more focused on quality issues. And we're talking about, high quality care, and that's broken down as being clinical effectiveness, patient safety, and also the quality of the patient experience, which is absolutely critical and hugely important for our learning. And we're talking about compassionate care, and I wanted just to kind of unpack what I think the academic literature tells us about how we can understand that word. It makes sense to me to understand it in terms of having 3 components. Compassion is about paying attention to people. And we saw many instances in the work that we did within trusts where patients were simply not attended to. People didn't notice them. And the second component, after paying attention, is empathy, is having an empathic response, is feeling for the other person, feeling for their pain, feeling for their fear, feeling for their feeling of being out of control. And the third component is the intention to take intelligent action. And compassion is paying attention, responding empathically, and intending to take action to help the other person. When we're talking about leadership and culture, it's therefore about how we create the conditions for that to occur. And that's about having an inspirational vision focused on patience and compassion, but then turning it into action, making it action, not just words. The second area I want to talk about is patient and carer engagement, because that's also vital in terms of our understanding of how we can deliver high quality care. And that, of course, is about involving the patient, sharing information with them, giving them some influence over decision making. And it's also about making sure that we're enabling them to be involved in the running of the organization, that they can make a difference to the organization. But what we saw, in trusts very often was that boards were never discussing patient complaints. In less than 18% of cases, did boards discuss patient complaints within their meetings. And yet patient complaints are an enormously powerful source of learning for organizations. In some organizations, what we saw was that they collected data on how many patient complaints had been dealt with and how they'd responded to them, but there was no sense of patient complaints being used as a source of learning for the organization. What does this tell us about our organization? What can we learn about our organization and to help us improve the systems within the organization? Indeed, I think a mantra within NHS organizations should be the question, what can we learn from this? What can we learn from this? Not have we dealt with the complaint, that's important, but what can we learn from this? We distinguished two patterns in boards in the analysis of the minutes. One was a pattern of what we called comfort seeking, where boards were apparently seeking comfort continually that they were fulfilling the obligations that they were required to fulfill for regulators, and where they tended to interpret the information to the contrary, which came from staff, as whinging, versus an approach that we called problem sensing, where board members were out in the organization seeking information which told them things they didn't know about the organization. So patient and carer engagement is not just about passively listening to patients, but seeking information that transforms our understanding of how we can create cultures that deliver high quality care. What can we learn from this? How can we change our systems to avoid these sorts of problems in the future? The third area is good people management for flourishing. It's kind of a simple message. If we want staff to treat patients with respect and dignity and care and compassion, we have to treat staff with respect and dignity and care and compassion. It's a simple equation, it's evidence-based, and it is absolutely fundamental to creating cultures that are caring and compassionate. If a nurse goes into work in the morning and encounters an irritable supervisor, manager, leader, we know from the research evidence that that affects her behavior for the rest of the day, and in particular, her ability or his ability to respond to patients in pain, in difficulty, or who are angry, or whatever. It depletes his or her emotional resources. It depletes their ability to think carefully. Did you know that if you induce positive emotion in a medic, he or she makes better diagnoses? If you induce negative emotion, it has the opposite effect. We human beings. When you link the data from the National Staff Survey to the patient satisfaction surveys nationally, what we see is that staff views of their leaders are strongly related to patients' perceptions of the quality of care. Staff satisfaction predicts patient satisfaction, and the more supportive people's report their immediate managers being, the more positive are patients about the experience that they have. It's kind of I guess it's understanding the idea cultures in organizations are not bits that you can segment up. We haven't got a culture for staff and a culture for patients. It is a human community, and if one group is feeling deeply unhappy, it affects the other group. And the patterns of behavior that we instill as the norm in relation to how staff interact with each other, leaders with staff, staff with staff, spills over into how people behave towards patients, and indeed how patients behave towards each other. The corollary is true. So when staff report high work pressure, patients say there are too few nurses and they're not treated with respect and dignity and not given the privacy that they want. When staff feel stressed and report low well-being, CQC indicators indicate poorer quality of care. And indeed, even the financial performance of hospitals is worse. So the evidence is there for the importance of managing people well, creating the conditions in which they can flourish as human beings. And that means not just good interactions, but also good human resource management practices. So we need recruitment, selection, appraisal, training systems that reinforce the values of compassion, of learning, of high quality care. So we're selecting, training, appraising people, not just on technical skills, but on their developing compassion, a trainable skill, on a commitment to constantly improving the quality of care that's offered within the trusts, the extent to which they take responsibility for improving quality. They take responsibility for promoting the effectiveness of the organisation overall. The third area that has emerged as really important from our work is the importance of staff engagement. It is the best predictor of outcomes in the National Staff Survey at organisational and individual level. So the higher the levels of staff engagement in a trust, the better the quality of care, as indicated by the CQC. The lower our mortality rates in the acute sector, the higher are the levels of patient satisfaction, the lower the levels of stress among staff. And engagement in the staff survey is conceptualized as having three components: advocacy of the organization, are we proud of our organization, intrinsic job engagement, and what we're calling proactivity. And the most important component is that last one, the extent to which staff are taking responsibility. When they see a patient who's not theirs, unable to reach the water to drink, they intervene. When they see a member of staff behaving compassionately with a patient, they go up and give feedback and appreciate the person's contribution. When they see somebody behaving rudely and briskly with a patient, they give feedback in a supportive way. People taking responsibility for quality. How do we create the conditions for staff engagement? There are many ways we can do that, but the most important, I think, is that we need to create positive environments for people. We know that human beings think better, are more compassionate, have more energy when they feel, for the most part, high levels of positive emotion. NHS organisations are characterised by pain and grief and fear and anxiety and loss of control. There is enough negative emotion in these contexts already. We don't need, as leaders, to add to it by being irritable, rude, aggressive, brisk, and failing to adopt behaviours that will really make a difference to the environment, of appreciating people, of being optimistic, of encouraging supportiveness, of building a sense of efficacy and confidence. So the role of leaders is to create positive environments. Nurses are the most stressed working group in the UK working population after teachers and welfare professionals. That has to change, because that's not a context within which we can deliver high-quality, compassionate care. Our leadership has to change to create positive emotional environments for people, given how much negativity there is already. And that also means dealing with the poor behaviors which undermine those cultures. So that means dealing decisively with individuals, however senior, who are aggressive, irritable, who don't talk to their colleagues, and dealing with poor performance decisively, so that we create a culture that is positive and flourishing and supportive and has integrity. And Jill has already mentioned the importance of team working, and our analysis indicates that probably about 50% of people in the English NHS are working in what we would call pseudo teams. It's as simple as making sure all teams have clear objectives, the most important issue, 5 or 6 objectives focused on improving quality, that they work interdependently and that they meet regularly to review their performance and how it could be improved. If we could do that, we're shifting the culture of team working And finally is values-based leadership at every level, the importance of leadership. We have a lot of research evidence on the importance of leadership. I've showed you some of that evidence already. We're working with CCL and the Centre for Creative Leadership and the Faculty of Medical Leadership and Management and the King's Fund to identify what's important in terms of leadership. We have lots of historical data showing the link between leadership effectiveness, clinical quality, patient complaints, and so on. But we're focusing increasingly on leadership being about direction, alignment, and commitment. And it is in making sure that leaders are giving direction to the whole organization. I talked about quality of care. It's making sure that's happening in practice, not just as rhetoric. It's making sure that everyone's efforts are aligned around improving the performance of the organization in line with that vision. And that means setting clear objectives, challenging objectives at every level of the organization. And it's about commitment, making sure that everyone in the organization understands it's their personal responsibility to make a difference to the culture and the high performance of the organization. This is about making sure that there is a collective responsibility. It's about making sure that everyone sees the success of the organization as a whole as their responsibility rather than just their area. I have to say that very often in working in trusts, I see senior medical staff commenting from the sidelines about the culture and the organization rather than seeing it as their collective responsibility to take the leadership of the organization forward. And that's not leadership if you're simply commenting from the sidelines. Cynicism is very cheap and highly corrosive within organizations. I talked about creating positive environments. Cynicism does the opposite. We think that every organization should have a leadership strategy about thinking for the future. What leaders do we need? Where do we need them? And importantly, how are we going to ensure that our leadership community creates a shared sense of purpose in terms of values and in terms of how we're going to work together as a community to take the organization forward. So instead of, to use the King's Fund's phrase from a couple of years ago on leadership, instead of having individual heroes, no more heroes, it's about how we create a collective leadership strategy within trusts. And the work that we're doing, King's Fund and the Centre for Creative Leadership, developing an approach to helping trusts achieve that kind of strategy. In the end, though, it seems to me that if we're to create cultures that really make a difference, that individual leaders must recognize that leadership is about personal authenticity and that we need to lead from our deep values, values of wisdom, wanting to learn in order to make a difference, the value of courage, the courage to persist in trying to change the culture of the organization, to deliver high-quality, compassionate care. About humanity, leading from humanity, the determination to promote kindness in relationships within health service organizations, and compassion, the commitment to prudence, of being cautious about how we work as leaders, and in particular, humility as a leader. There's emerging research, a lot of emerging research showing that humility as a leader is fundamentally important for creating the circumstances in which people will engage. And the prudence to be careful about being angry. I've made my worst mistakes as a leader when I've been angry, instead of waiting 24 hours before I send that carefully typed out 11 p.m. email with the keys smoking on the keyboard. Instead of waiting 24 hours, or better still, going and talking to that person face to face, compassionately, paying attention, feeling empathy, intending to take intelligent action. And it's about justice, creating, as a leader, circumstances where people feel that they are treated fairly and equally and transparently and openly. And about reclaiming that sense of wonder and optimism about the work that we do within healthcare. These are communities that are focused on caring for other human beings in the community, where optimism is important, where we have a sense of the importance of humor, which creates positive environments, and where we have a sense of the significance socially of what we do. Now, I saw my children born in NHS organisations. Those were the peak experiences of my life. I lost people who were really dear to me and saw in NHS organisations and saw the most amazing compassion from complete strangers. If we lose the value of the kind of communities that we're trying to create by not operating as leaders from our hearts, not just our heads, then we lose what is, I think, fundamental about the founding vision of this amazing service. Thank you very much.